but it's my pleasure to introduce Dr. Eliana Gheorghe, who's the head of the Department of Gastroenterology and Hepatology at the Fundeni Clinical Institute, Davila University of Medicine. She's the president of the Romanian Association for Liver Disease and the scientific coordinator of all Romanian health programs on hepatitis, and she'll be joined by Dr. Cora Pop, who's the professor of internal medicine and gastroenterology at the same institution and also at the University Emergency Hospital in Bucharest. Thank you both.
Thank you very much, John. Dear chairpersons and dear colleagues, thank you very much for inviting me and giving me the opportunity to address the efforts and the country perspectives in hepatitis C elimination in Romania. First of all, I have to disclose something. I'm not a public health specialist, actually. I'm a gastroenterologist and hepatologist and transplant hepatologist. And so I see this patient at the end of their journey, and that is impressive. And that decided that had a huge impact on me, engaging me in this activity. I think I will start by setting the epidemiological background for Romania, because I don't think you know it. Actually, I start with this nationwide cross-sectional survey among adult population in Romania that has been conducted between 2006 and 2008, and it is rated, this study is rated as a high quality input data. It was performed on more than 13,000 subjects tested in our country that times, and the seroprevalence rate in Romania was found to be 3.23 and extrapolated for all ages 3.3. with a significantly higher rate in females, in rural residents, in older than 50, in those exposed to nosocomial risk factors, and of course with significant geographical differences in our country. Using this data to forecast the HCV prevalence and the disease burden, and in estimating a year of achieving the absolute WHO goals of HCV elimination, we have this study, this modeling study performed by Polaris collaborators, Polaris Observatory collaborators. Also in our country, it was an important interaction with CDC, but not at the level of Georgia. You can see here in this modeling study that Romania, the level of 2020, has an estimated rate here of 2.3% of HCV infected individuals among the entire population. And that's mean in Romania are still living more than 400,000 individuals with hepatitis C, and Romania remains a hotspot on the European community map. Going further, the estimated year of achieving the absolute elimination targets in Romania, the current rate of diagnosing and treatment, it's far from 2030, as you can see, in the same modeling approach of the Polaris group of the CDC. How can we improve this country response? What have we done in this regard? I will show you in the beginning some preliminary efforts previously and during the COVID pandemic. because realizing as a professional group that there is a lot of things to be done in Romania, we wanted to add something to the national elimination plan as professional community. And we, first of all, we set our priorities and engage in some critical initiatives. Actually, we increase awareness in general population by structured campaigns. We met the political authorities, increasing the interest on political and public agenda of hepatitis C and viral hepatitis in general. We try to have many intervention in media to avoid public stigma and to include for the inclusion of these patients. We try to deliver educational programs. We succeeded actually to eliminate all the restriction in access to therapy. The only limitation, fibrosis, alcohol dependence, age, and so on. And the only limitation that we have now is for uninsured people, but we have also in this regard a legislative project in public debate and hope to eliminate it soon. Our patients, starting with 2015, received, we started with almost 6,000 persons that can be treated annually, but now this range is in between 8,000 and 15,000 treated yearly. We try to eliminate the periodic gap of 1 to 4 months between the annual therapeutic contracts during which a diagnosed patient cannot be treated. And mostly, or the most important direction in which we acted to develop articulated screening initiatives and programs to uncover those that have been never tested, they don't know their HCV status, and to focus on underserved and hard-to-reach population. We realized that we can improve the diagnosis and access to treatment by activating screening, which is considered to be the engine behind all elimination programs. So we have to find, we must find the missing thousands of HCV-infected subjects in our population. And we developed in the beginning some pilot initiatives conducted by the Romanian Society of Gastroenterology and Hepatology, showing that this approach can work, can add a number of patients, HCV patients, to the global number that has been discovered during the national program. So we have several campaigns, the Hep C alert during the 2019 and 20. More than 50,000 subjects have been tested in medical units, and the hospital-based seroprevalence was found to be 1.39. And all these patients, most of them, have been linked to care in the same hospital unit through the gastroenterology and hepatology departments. Then we have an educate, test and treat campaign in the isolated rural communities from the northeastern part near Moldavia of our country, where the prevalence of hepatitis C is quite huge, is the highest. And we found here 2.65 HCV seropositive individuals, and they have been treated in Iași Regional Gastroenterology Center. And in southern Romania, in Oltenia region, we have several campaigns, screening campaigns on more than 15,000 subjects tested with a lower prevalence, but devoted to small industrial cities, active mining towns, in energetic complex Oltenia or in several car manufacturers in that part of the country. And during this comprehensive, let's say, microelimination approach, we identified two main trends. The first one was a favorable trend in the prevalence of active HCV infection with a reduction by nearly half, because, of course, also the aging and death of all the infected cohorts, but also after 6 or 7 years of using DAA. And the second trend, we still have some endemic pockets where our efforts should be concentrated, such as rural communities, socio-economically disadvantaged population, and northeastern Romania. And looking at this kind of approaches to the liver screening in population, we try to blend them. First of all, we have HCV testing, including in the basic insurance package and performed by family practitioner in all insured individuals, and they are more than 90% of our population. But a part of this primary care involvement in screening, we focus on two types of population: the vulnerable, underserved population, and screening. We have also a screening program for incarcerated people across the country that Cora will present furthermore. Okay. Let's go further. So we continued our screening efforts through this Liver South and East twin programs. Recognizes a huge problem that Romania still has with viral hepatitis. The European Commission accepted to fund Romania for a 40 months long screening program. This is Livero, a regional program for the prevention, screening, and diagnosis of chronic disease, chronic liver disease following HCV-HBV infection. It should have started in July 2020, but because of the pandemic, it was a delay, and we actually started in July 2021. On 28th of July, the Hepatitis Day, and the endpoint is expected to be at the end of November this year. Which are actually, because it is ongoing, still ongoing, the objectives to provide high quality medical services for prevention, detection, and linkage to care for previously undiagnosed HCV or HBV infected adults, being part or coming from socio-economic vulnerable groups, and the secondary endpoint to update the prevalence of viral hepatitis in vulnerable population in our country. These are the programmatic targets. Actually, together, the two twin programs should test a quarter of a million individuals from these categories. But also you can see here that the programmatic targets have been already reached and even exceeded. The target population, it is important to underline, is a rural population, especially from isolated communities, poor people with low income, below the medium, the minimal guaranteed salary in Romania, the uninsured people, the homeless, the people with no identity documents, the institutionalized in different facilities people, adults coming from orphanage or adults from monoparental families, subjects with disabilities or with special needs, the Roma communities that create a great problem in Romania, the people who inject drugs and other types of addiction, victims of domestic violence or human trafficking. And going further, I have to say that the data obtained from screening and staging in this program have been introduced into a specific registry for screening evidence in viral hepatitis, managed by the National Public Health Institute. And this electronic system has interoperability with the National Registry of Vaccination. And it seems to remain the electronic system to register all the infected subjects with viral hepatitis, and has two levels of password protected access. The first one is the level for family practitioner. As you can see here, the name of patient, the patient is anonymized. There is a code for the patient, a code for the doctor, and the service is rendered, and the results are introduced in this database. And here on the left, on the right part of the panel, the right panel is the section for the specialty care, where you can find all the virology and staging data in each individual subject. And going further, how the process was set. First of all, we identify an NGO, a non-governmental organization with a huge experience in this area. Over the last 30 years, this Romanian association, anti-HIV, anti-AIDS, and anti-hepatitis has been engaged in identification, in navigating, and in linkage to care of these patients. So they have this precise role in our program to identify, to ensure the access, and to navigate these patients. Then we recruited the facilitators, the general practitioners who wanted to be affiliated with our program, in between 23 and 61 per county. And as you say, there were 24 counties, a huge number. Now I think there are more than 900 general practitioner engaged in this program. The screening population has been identified, invited for a visit at the general practitioner office, where if they signed, agree, consent, they receive a risk factor questionnaire. Then they have been tested. The data have been introduced in the electronic system. The result was communicated, and the patient received, the positive patient received an appointment for the specialty care. And also for this transportation of positive patients, ARAS, Romanian Association Anti-Hepatitis and Anti-HIV, was involved. And in specialty clinics, they have been linked to care. The viral infection has been characterized, and also we perform disease staging and diagnosis. And this patient, if was the case, were included in treatment and monitoring. So this is a flow chart. It's easy. Adults residing in a selected area with previously unknown hepatitis status, 60% of them coming from vulnerable population, contacted by the affiliated family practitioner and invited for one-site visit. Here testing and risk factor questionnaire were performed. Data have been introduced in electronic system, and then ARAS appointed this subject and accompanied them in specialty care. So, and here you can see how the process goes on in the specialty care. They have been investigated. They underwent elastography, ultrasound, and routine liver function test, as well as virology for viral hepatitis. And here are the preliminary results on 6th of June this year. The project is still ongoing until November. You can see here, until now, we exceeded the targets. Instead of 240, we have almost 300 subjects already screened. You can see here the flow of screening in between 6,000 and 24,000 screened per month, with several gaps during the pandemic waves, as you can see here. And the seroprevalence overall was 1.21, as you can see here, again with significant differences between the southern part, 0.8, and the eastern part of Romania, where the seroprevalence is 1.73. And going further, both programs have already fulfilled the programmatic targets, as I said, a total number of 3,551 previously unknown HCV positive subjects have been detected in our study with these rates of seroprevalence, but the viremic prevalence was also significantly lower than before for the southern part, 0.58, for the eastern part, 1.13, and globally 0.82 viremic prevalence now in Romania for HCV. There are some statistical significant differences between different groups. For example, females were much more affected than men. People living in rural communities, older age cohorts, people with greater number of risk factors, the partners of C or B infected individuals, those with low education, single or divorced or unemployed. So you can see here that we identify 10 counties among the 24 that have been screened, 10 counties where the prevalence is higher than the media, and these are almost all located in eastern part, and here we should enforce our efforts of screening. And I could say in this moment that the specific profile of HCV-infected individuals in Romania is the following. He or she comes from probably Eastern Romania, is a female person, older than 60, living in rural areas with 2 or 3 risk factors, with no or low educational level, and many of them unemployed. What about the results of the staging? Only 2,874 positive subjects were staged until now. You can see here the virologic evaluation. 76 of them were viremic positive, but the therapy uptake was seen only in 58% of those eligible. And as you can see, we have another problem. The disease, the HCV disease, is now diagnosed in F2, F3, and F4 stages in our country. 73% of these seropositive patients have F2, F3, or F4, and almost 60 were pre-cirrhotics or cirrhotics. It's a difference between this HCV infected cohorts as compared with HBV infected ones. Which are the achievements and setbacks of our program? We have some encouraging results. I can call them achievements. A drop in prevalence among young people living in urban environment with high educational levels. So the patients between 18 and 60 years of age have an anti-HCV prevalence below 0.59. Patients in urban areas below 0.61, and those with high education below, again, 0.6. But we have also several directions for action. Hepatitis C in Romania is still a nosocomial infection affecting older patients exposed during the 80s epidemic. The rate of linkage to care, it's a matter of concern, and treatment uptake also should be improved. We are thinking to support programs, teams with dedicated psychologists, ensuring and to fight with our authorities to ensure the continuity of therapy at the legislative level, avoiding these gaps during which some of these patients drop off. The therapy for uninsured people is still a problem, and the stages at which hepatitis C is diagnosed in our country continues to be a problem. F3, F4, approximately 60% of the HCV infected population. That means they continue to require attention, medical attention, and to be retained in medical care. So my final and motivational conclusions as following: any screening is better than no screening, and there is a remarkable drop in HCV prevalence in Romania, and this is due to the combined effort of the entire community, professionals, patients organization, non-governmental organizations, civil society, media, political will that we succeeded to change. In the end, the focus now is on high-risk population. Screening for viral hepatitis should become a permanent activity as part of the standard curricular practice of every GP and specialist. We have to improve linkage to care by education, awareness initiatives, legislative changes, including permanent access to therapy. I think that the National Viral Hepatitis Eradication Plan needs to be updated with this data, And I think that blending our expertise and the political will, the elimination of viral hepatitis in Romania is not far from becoming reality because all the ingredients are here. And I hope that as soon as possible, hepatitis C will remain a simple word, not a sentence.
Fantastic. Thank you. So many lessons learned there in that overview. Thank you. Cora, did you want to make some remarks right here? After the break, yeah.
I don't know. You decide.
Okay, we can do it after the break. Yes.
The same group of initiatives addressing the issue of incarcerated people. I'm sorry. If you consider, we can join the.
Okay. Go ahead. Do you have any other comments, questions? Yeah.
Thank you. Erica Castro, GP and addiction medicine specialist based in Switzerland. I loved your talk because this is what we all want to see, how to implement strategies and models with all the people that is involved in the patient's journey. And I think it's great. It is, in fact, very, very important, this finding of very advanced fibrosis and cirrhosis in the new HCV infections you're detecting, which I can believe could be related to the fact that people are long known for, or have been long known for HCV, or perhaps not. And eventually what this means also for the future for hepatocellular carcinoma prevalence in your country, unfortunately. So my question is, as you already have GPs as a component of your model, why not decentralize also liver stiffness staging? Because we have very easy to do FibroScan and many other technologies.
Excellent point, Erica. Actually, what I want to say is that the country specificity in Romania, it's a strong bond. I can say that. A strong bond between primary and specialty care. They have special dedicated groups devoted to cardiology, gastroenterology, and they cover with this group of interest all the country. And we have a very good collaboration. Actually, now we have a pilot study through family practitioner trying to identify from the primary care people with advanced liver disease, F3, F4, using Forns index, using EPRI, irrespective of etiology. And they discover these people and link to care, send them further to the specialists, and retain in primary practice only those having F0, F1, F2, because that is a problem, having an old infected cohort. We have now most of them in advanced stages of fibrosis, prone, and we have an important percentage of them on the list of liver transplantation with or without hepatocellular carcinoma.
Thank you. Anything else? I think we can continue the conversation after the break. Thank you so much. We'll take a break for 15 minutes.